of the conference. For this, our moderator will be none other than Dr. Shravani Chakraborty. Ma'am, please grace our stage with your presence.
Very good afternoon to all of you. So we have come to the concluding session of our second day. Practically, this is the last session before lunch. This is a panel discussion. So it's the autoimmunity, the road ahead. The panel. There are eminent speakers in the panelist. So I'd like to invite on the stage our eminent panelist. Dr. Biman Saike, please. He is there with us since yesterday. He had his talk just now also, so he doesn't need any more introduction. Dr. Shyamashis Das. Dr. Das is a rheumatologist. He is attached to INK. Dr. Arupratam Datta. He's a senior consultant nephrologist in Fortis Hospital, Anandapur and Rajbihari, Kolkata. Dr. Partho Guchai is a microbiologist associated with the PLS Hospital. Dr. Shormishta Chaudhary. She's an eminent biochemist. And last but not the least is Dr. Shangumitra Mukherjee. You also know her pretty well, doesn't need any more introduction. So I welcome you all on the stage. Since yesterday, we had been hearing a lot about autoimmunity and we have gathered a lot of knowledge about autoimmunity. But still, with the eminent speakers with us, we'd like to have a little bit of more discussion as a concluding session. So autoimmune disease, we know it's a condition where the immune system mistakenly attacks the normal, healthy cells of our body, which can be organ-specific, which can be system-specific. And we have got a plethora of the tests to detect these all the diseases. At times, we are really confused how to proceed about it. So that is the reason we thought that will be a good topic for discussion, and we have got the panelists with us. So first of all, I'd like to ask Dr. Partho, like ANCA, whenever we think of the autoimmune disease, the two common tests which comes to our mind is ANA and ANCA. So regarding ANCA, I'd like to ask you, like, which one is the preferred one? Which was the preferred method of test? Is the IIF or the ELISA? And why?
Okay, good question, ma'am. The ANCA can be diagnosed by both IFA as well as by ELISA. Both of the technique has its own limitations because we know that some 10 to 15% of the seropositive ANCA positive patients by IFA give negative result by ELISA and vice versa. So if we go by the advantage and disadvantages of these two techniques separately, we'll see that we need to have 3 substrate-based assay for detection of ANCA by IFA. Each of the substrate has its own advantage because the substrate granulocyte with formalin, it will give you the clue whether it is atypical or typical ANCA. That will help clinician to narrow down the diagnosis, whether they should treat it as AAV or non-AAV. And then another important thing is if we go by consensus, then the older consensus says that you need to parallelly use both IFA and ELISA to diagnose AAV and non-AAV. And it encompassed whole spectrum of the autoimmune diseases. But the disadvantage is you have to wait for the IFA result to become positive and then confirm it by ELISA. But in the newer consensus, they actually narrowed down the spectrum of disease. They only concentrated on ANCA-associated vasculitis rather than non-ANCA-associated vasculitis. And more importantly, they need ELISA. The third generation ELISA is the initial screening test rather than going for IFA. And irrespective of the positivity of the ELISA, the finding needs to be confirmed by a second immunoassay or IFA. Okay, so this is the recent consensus what says. But again, in 2010 consensus, they again expanded the disease spectrum. Again, they have included EGPA as well as the interstitial pneumonitis taken into consideration.
Okay.
So the combination of both tests is desirable, not a single one.
Right. So, Dr. Das, please, like how ANCA is useful in the diagnosis and the follow-up, or rather how it helps in prognostication also?
How ANCA helps in diagnosis?
Diagnosis and the follow-up.
Yeah. ANCA or anti-nuclear or anti-neutrophilic cytoplasmic antibody, this antibody is a part and parcel of investigating small vessel vasculitis. ANCA-associated vasculitis is small vessel vasculitis, and while we are suspecting clinically a small vessel vasculitis, we have to go for ANCA. And we know that in ANCA-associated vasculitis, there are mainly 4 diseases. One is GPA, granulomatous polyangiitis. Second one is EGPA, eosinophilic granulomatous polyangiitis. Third one is MPA, microscopic polyangiitis. And fourth one is renal limited vasculitis or post-immune glomerulonephritis. So these are the 4 diseases. So when we test ANCA either by ELISA or by IIF, immunofluorescence, as mentioned by our previous panelist, Dr. Guchait, that for the screening test, ELISA is the best because this is the most specific. So when we are doing by any of these methods, we get ANCA positivity in almost 90% to 95% cases in GPA and MPA. That means this is very sensitive in active disease especially. And in case of MPA, this percentage is a bit less. It is maybe 70 to 80%. No, it is again in MPA it is also around 90%, but in EGPA it is less. It is around 50%. And in renal limited vasculitis, it is 70 to 80%. This is more or less the rate of positivity. So this helps a lot in diagnosing, especially active ANCA-associated vasculitis. So does it mean that negative ANCA excludes ANCA-associated vasculitis? No, because nearly 10% of patients, even GPA, can be diagnosed without ANCA positivity, because especially a limited kind of GPA where kidneys are not involved, say only the upper airways are involved, in those cases sometimes we get ANCA negative. So this way it helps in diagnosing ANCA-associated vasculitis. Now regarding prognosis, PR3 ANCA, ANCA are of 2 kinds, PR3 ANCA and MPO ANCA, antibody against proteinase 3 and antibody against myeloperoxidase. And if patient has PR3 ANCA positivity, then chance of relapse is more. So that way you can help in prognostication, whether this patient will have further recurrence in future or how frequently they are going to have recurrence in future. So PR3 positivity is bad prognostic factor, and persistent positivity of the anchor titer is another bad prognostic factor. Also, anchor titer may be used, though it is not universal and it is debated, it may be used in monitoring disease activity, how the disease is controlled, whether patient is in remission, or if patient is in remission, we stop the immunosuppression, whether we should, whether we can predict the relapse of the disease, ANCA-associated vasculitis, the relapse with the anchor titer. That is debatable, but it is also useful in such situation, in monitoring diseases to predict relapse.
Okay. So moving to Dr. Saigya, like we have discussed a lot about ANCA. So what are the other autoantibodies we can test beyond these ANA and ANCA?
Yeah, as you said, when you talk of autoimmunity, you tend to think of ANA and ANCA. But the world of autoimmunity just is beyond ANA, ANCA. And when you talk of ANA, ANCA, you're basically dealing with diseases which are B-cell mediated, kind of, and we're depending on the antibody detection. And there are a lot of T-cell mediated autoimmune disorders which we actually totally, there's no method to detect the T-cell mediated in the laboratory at least. So there are a lot of other antibodies, and it totally depends on what your clinician wants, and that's where it's important to have a dialogue with your clinicians. And you ultimately, for example, in my experience, let's take the example of celiac disease. A lot of you must be doing the TTG assay. But one important thing to remember in TTG IgA ELISA is that if the clinical features are very strongly suggestive of a gluten enteropathy, and the TTG ELISA is negative, you have to look at the IgA levels. So in case the patient has IgA deficiency, then your TTG IgA ELISA would not detect the antibodies. So then you have to go for the IgG ELISA. So that kind of a situation. And in my experience, employing a neurology panel has been of great value. And if you have your neurology colleagues who are looking at autoimmune encephalitis or the neuromyelitis optica group of disorders or the paraneoplastic syndromes, so your neurology friends must be struggling to deal with these cases. So employing the neurology panel is a very good idea. At least in my experience, we had a lot of fruitful diagnostics with employing the neurology panel. And so there are a lot of autoantigens available, and we test only those which are available commercially. And to bring antigen detection method to commercial level, that particular autoantigen has to be sensitive, specific, it has to be scalable, it has to have a clinical advantage, then only it comes to production, right? So there are a lot of autoantigens which are there in literature if you go through, and these are called the orphan antigens because nobody adopts them to the commercial level. So there are a lot of testing that is beyond ANA and ANCA, so we have to keep that in mind.
Yes, probably depending on the clinical symptoms and having a dialogue with the clinicians, I mean, we can proceed forward what are to be done. Just going back again to Dr. Das, like I'd like to ask you, what is the clinical correlation between the P-ANCA, C-ANCA, and the atypical ANCA? You know, like whenever we speak of autoimmunity, ANCA is something which always comes to our mind. So just thought of asking you this.
Yes, ma'am. So, three kinds of ANCA has been described. C-ANCA, that is because of presence of anti-proteinase 3 antibody, anti-PR3. P-ANCA or MPO, anti-MPO, myeloperoxidase, and another is X-ANCA. So, PR3 ANCA, that is C-ANCA, is seen in GPA, granulomatous polyangiitis, or previously known as Wegener's granulomatosis. And mostly in 90% of GPA patients are positive with this antibody. However, a small fraction of these patients, maybe 10%, are positive with P-ANCA, but majority of them are not. And P-ANCA positivity is seen in both the microscopic polyangiitis and EGPA, and also renal limited vasculitis. So, and thing is that this C-ANCA or P-ANCA, those are termed on the basis of their appearance under immunofluorescent microscope. C-ANCA is there is staining in the cytoplasm only. C-ANCA, C for cytoplasm, and P-ANCA is perinuclear. Only the outer surface of the nuclei of neutrophil get the stain. That is, it's called. That's why it's called perinuclear P-ANCA, and the other one, the X-ANCA is, or it is also called atypical ANCA, when there is patchy staining around the nuclei, which is also called atypical P-ANCA. So this atypical P-ANCA is found in various conditions, and and not because of PR3 or MPO positivity. That means if we say we get X-ANCA or atypical ANCA, if we test for C-ANCA and P-ANCA through ELISA, both of them will be negative. So X-ANCA is because of other neutrophilic antigens, maybe lysozyme, maybe lactoferrin. So, and the X-ANCA positivity is found in various connective tissue diseases like MCTD, lupus, IBD, and also in autoimmune hepatitis. So, these antibodies are related with various diseases.
Okay, thank you. So,
I'll add on one thing. So to cover all this spectrum, the whole spectrum of atypical and typical ANCA, better we should go for the ELISA, which includes all. Okay, the Euroimmune has this kind of ELISA, which includes both MPO, PR3, then the lactoferrin cathepsin G, the full panel. So if you go for that, even the consensus says so. So that will increase our time and save the cost.
thank you for Parthu.
Can I
So
just
now-
add one line?
Sure.
When you're looking at the ANCAs by immunofluorescence, you report a C-ANCA only when you see the interlobular accentuation in the neutrophils. Unless you see that, don't call it C-ANCA. The staining will be intense in between the lobules rather than in the periphery. Where it is an atypical C-ANCA, the entire cytoplasm will blow up. And in a P-ANCA, you have to see those blebs and the intranuclear extensions. Unless you see that, don't call it P-ANCA. So it's, that's how you increase the specificity of your the immunofluorescence assay. You have to be very critical in calling it C-ANCA or P-ANCA.
Actually, yesterday there was nice demonstration, nice pictures of P-ANCA and C-ANCA. All of us who were there yesterday, we have seen. And it was stressed upon that blebs should be present, as you reiterated now. So let me go to Dr. Datta to understand, what are the renal manifestations of autoimmune disease, and how, from the clinician's perspective, as a nephrologist, you'll move about it?
Thank you. So as you know, in nephrology, we go by the syndromes. There is a kind of a syndrome we attribute to the presentation, and they vary. There are about 10 syndromes, starting from asymptomatic urinary abnormality, where some abnormalities kind of picked up on a routine testing. Patient is completely asymptomatic. From there to nephrotic and nephritic syndromes, which is kind of all of you know, to AKI, acute kidney injury, and even chronic kidney disease. Now it has become commonplace now, even in a CKD, that if you don't have an obvious cause, like somebody not hypertensive diabetes for long, somebody with a very long history of that, we may not always test for it. Any atypical urinary sediment, any sudden rise of creatinine, or trajectory of creatinine, which is not matching with the usual thing that you anticipate in a CKD, we would test for the autoimmune things. And we generally send ANA-ANCA C3 mostly, and depending on the presentation, we add the anti-GBM. And in nephrotics, we also are doing the PLA2R in the last 10 years or so. This has helped our understanding of the thing. Now, so the pickup rate is kind of different depending on the presentation. Most asymptomatic urinary abnormalities will eventually turn out to be a IgA nephropathy. Unfortunately, we don't have a good marker for that as yet in the blood. So you have to depend on a kidney biopsy if the abnormality persists beyond a certain length of time. For nephrotic syndrome, we would primarily see lupus, and we will also see the membranous nephropathy, for which we have a marker now, the PLA2R. And it's good that if you find a PLA2R, you can actually withhold doing a biopsy and then start the treatment right away. So there's a bit of support from the lab in this case. If it is a nephritic presentation going on to an RPGN kind of thing, it can be lupus, and there comes the ANCA, actually. And sometimes in a CKD, like a young patient comes with a CKD, and kidneys are not biopsyable, we sometimes do the panel also. Because just to give us an idea, we know that we won't be able to treat much, but at least we have an idea of what caused it, because it has got relevance during the transplant, if and when we are going to do. Now, I want to focus on the RPGN presentation, which, as you know, the rapidly progressive glomerulonephritis, which means generally the creatinine rises in a period of few weeks, and mostly they would have a nephritic presentation. This is something like a nephrological emergency. I just put it like that. Short history, the typical presentation will be like this. History is very short, 3 to 4 weeks history, maybe 6 weeks. Patient unwell, there may be fever, maybe joint pain, may not be anything. Somebody does a urine test, there is a nephritic picture, albumin, RBC, some cast. Creatinine, 2 to begin with. In 10 days later, this becomes 3.5. By the time they reach us, it's already 6 or 8. So this is a nephrological emergency. So what do we do here? We would admit the patient. We start treating them. We'll send the panel immediately, and we want a very, very quick feedback from the lab. Fortunately, nowadays, within 2 days, we are getting most of the reports. But sometimes we do call you up and say that, oh, give us a report faster. We will begin dialysis if they're in the dialysis zone. We'll start steroids without waiting for the reports, because time is essence here. And then we will do a biopsy after 2-3 dialysis. And by that time, we have given some Solomedrol. Now, it's about maybe 2 or 3 or 4 days max after the presentation. We have done all this, and it's time to get back the reports. The ANCA reports, everything sort of come back at this time. And if there's a clear ANCA or an anti-GBM, then you may not do the biopsy. You can actually proceed with the treatment, but mostly by the time we get the report, we would have given the steroids already. Biopsy, about 60% it would have been done already. And to correlate the thing, we look at the chronicity, and then you give the full immunosuppression after that. So this presentation is really kind of horrendous presentation, I would say. And you feel happy if you're able to diagnose and treat on time. It all depends on the creatinine at presentation. The creatinine is more than 5, 6, you've already missed the bus, basically, by and large. So, but if you can catch very early, 2.5, 3 creatinine, you should be able to salvage. So that's it.
Thank you. So let's come to our biochemist, Shormishta. So what are the platforms used? We had been discussing about all the antibodies and what other markers and how we can proceed, but I'd like to know what are the platforms we use for all these tests.
Thank you, ma'am, for the question. Actually, from the biochemist perspective, we are mainly concerned with the non-invasive diagnosis. So we have some limited platforms, but we are slowly expanding. Classically, ELISA has always been the mainstay. But nowadays, we have advanced ELISA platforms, like we have the bridging ELISAs, because many of these antigens, they have very specific epitopes where, there's a bridging mechanism by which an antibody binds. So we have advanced beyond that. Apart from that, of course, chemiluminescence-based assays or fluorescence-based assays are always a far better alternative. Chemiluminescence actually detects far higher amount of antibodies. They can detect up to there's a big birth of antibodies that it can detect. And on the other side, on the flip side, it can even detect very minor amounts, say up to zeptomoles or attomoles also. Fluorescence-based assays are also an alternative, but the problem with fluorescence-based assays is that whenever we talk of fluorescence, we have to take into account a certain phenomenon which is known as quenching. So if there are some cross-sharing epitopes of those antigens, then the autoantibodies, they may suffer from the quenching effect. So that we have to consider. Then radioisotope-based assays have always been there, like the RIPA assay. But those, because of the hazards of radioactivity, they have been largely replaced by fluorescence assays. And now, with the advent of molecular biology, we're having a kind of rehash. Like we have the antibody detection by the agglutination PCR, which is very interesting mechanism because it actually involves the antigen tagged onto a segment of the DNA. Again, to which the autoantibody binds, and the rest is like a normal PCR. Then, of course, when it came to detection of the anti-dsDNA, I'm sure we all know we have the Crithidia mechanism by which, the double-stranded DNA antibody binds to the double-stranded DNA, which is the antigen. And so we have made a long progress where actually we do not need to go for biopsy specimens at the very outset. And apart from these techniques, if we just, take a moment to go aside out of the technological aspect, the basic and the biggest advantage which serum-based assays they offer is that often they manage to detect autoantibodies even before the first symptom has taken place. So that way, the kind of mechanisms which we offer from the biochemistry point of view can actually act as the predictive markers. They can detect the predictive markers. And this is very important for diseases like autoimmune thyroiditis, which is often devastating, or worse when we talk of type 1 diabetes. So serum-based assays can actually detect these autoantibodies even before the first symptom occurs. And if that can be done, if they can be used as screening mechanisms, then it is extremely beneficial to the patient. And of course, it makes the clinician's job that much easier. So these are some of the modalities which we can go for. Apart from that, of course, from the diagnostic point of view, once the disease has set in, it's anybody's ball game. So there is not much credit in that genre. But then again, the third and the most important perspective, again, which we shouldn't forget, is the prognostication. Because many of these autoantibodies do offer prognostication. ANCA, unfortunately, doesn't. We have been talking a lot about ANCA, so I have to add that the ANCA doesn't have much therapeutic potential. But many of the other autoantibodies do, like anti-CCP does, and it correlates well with radiological pictures. The anti-TPO, it correlates well with the thyroid profile. So like we have the 21-hydroxylase autoantibodies in case of the primary adrenal failure, in case of Addison's, that correlates well with the plasma renin activity and the cortisol levels. So in the combination biochemical tests, they do offer a lot of scope for autoimmune diagnostics. Thank you.
Thank you. So something you told that it helps before the disease is manifested, right? You might have the antibodies in the serum. So this is a very tricky situation actually. So in those cases where you don't have disease manifestation, but you have the antibodies, so how do you proceed in those cases? It's very difficult to release the reports. So how do you proceed in those cases?
See, ma'am, if the antibody is positive, even if there are no symptoms, then naturally one is at a kind of a crossroad, whether it is a case of a false positive or whether it is a case of actual disease. So there, we have to report a bit confidently. Like, yes, we have detected the antibodies, suggested correlation, and if there is no clinical correlation, as in there is no symptomatology, then regular follow-up. We should always advocate from the laboratory's point of view, as a part of our advisory service, that there should be a regular follow-up after 3 months. Whatever the case may be, because this is very important. If this persists, then naturally one is always on the lookout for the symptoms to develop. For example, when we talk of the islet cell antibodies, now the Juvenile Diabetes Research Foundation, the JDRF, and the ADA, they have clearly recognized the importance of biochemical tests in detection of the islet cell antibodies, which are often extremely detectable to very high percentages with total normoglycemia. At that stage, the child or the adolescent is absolutely normoglycemic. And if you can detect those antibodies, and definitely it merits follow-up. And in follow-up, it has been seen that if untreated, they do progress first to stage 2, which they have defined as dysglycemia, and finally to stage 3, which is overt hyperglycemia. And then, of course, there's always the dreaded complication of DKA. So we want to avoid that entirely. So that is why when we are faced with such a scenario, when we are at such cross purposes, then it is very important to release the report that yes, we have detected this, and we are advocating serial measurement after, say, another 3 months. And then if it is persisting, then of course, on clinical suspicion, the patient there has to be a sort of a vigil. So that is very important. We just cannot say that, okay, this is a false positive, because taking into account, say, the age of the patient, the gender of the patient, so some of the things, those are the risk factors already in place. So we need to follow up. And we can do that confidently, provided we are confident with our platform, of course.
I was coming to you only, like in this scenario, when like a report has come up where you don't find, you are seeing the patient, examine the patient, and you have given some lab test, so you don't find any disease manifestation of that particular patient. And lab test gives you that particular antibodies are present. So how do you go about that? What decision do you make and how do you make the decision?
This is a very important question. I think probably the most important today. So I'll describe 3 case scenarios, and these are sort of real. I've seen over a span of time maybe. The common thing that we see now, that we would send a panel, but we have a low index of suspicion, but we have to do the panel in any case. Typical scenario will be a young boy, a young guy maybe in 20s and 30s. The kidneys look chronic, but they always present late. Kidneys look smallish, but with raised obviously this CKD is a very asymptomatic disease till the last. So they present when they get uremic symptoms. By that time, the kidneys have shrunken already. There's no reason to actually suspect an autoimmune disease, but more for the sake of completeness, nowadays we do send the panel, and sometimes the ANCA comes as positive. And even otherwise also, we are seeing a lot of p-ANCA positivity, which eventually turn out to be false. So this is one aspect. We know in the background that p-ANCA, sometimes there's a high false positivity of that. If the report comes as positive, we'll send the PR3 and the MPO. It's not that we don't restrict to the only MPO, we send both, just for the sake of confirmation. Eventually that will come negative in this kind of a scenario, when the kidneys are already kind of small. The other area is just the opposite, actually. And this is a real case. I mean, my uncle's friend, his wife, about 2 years back, was having some non-specific symptoms. So you can't really say that patient didn't have any symptom at all. It was not, because nobody will advise an ANCA as a routine test. Like you have the wellness panel, nobody does include it there. It has not become commonplace as yet. So obviously there were some symptoms. What somebody suspected, I don't know, they send like rheumatoid factor, ANA, ANCA. The report came as positive. Patient has a normal kidney function, and patient had a normal urinary analysis also, maybe very, very non-specific something. So they saw the physician, and they went to a nephrologist, and everybody thought that this is probably a false positive report. She has got nothing, related to that side. Kidneys are okay because urine output okay, the urine is bland, and the creatinine is kind of normal. She went on having those non-specific symptoms, and in 4 weeks' time, she was on dialysis, and that kidney could not be salvaged. The other point here is, we assume that, sometimes there's an antibody and it will have its own course, and you think that the course is going to be a linear course. The clinical course can be anything. You're going all right, and what's the trigger, you don't know. Suddenly everything, all hell breaks loose, and you just lose your kidney. It can happen in 4 to 6 weeks' time. So what she said, I fully agree. It is suspicion, and you have to be on follow-up. The caveat is that follow-up is what kind of follow-up? Would you ask for every week? That also becomes too much of a thing. So this case, I often think that what we could have saved. Anybody would have asked this case to come back in about a month's time. I mean, not really before that, but a month's time it was kind of gone. So, you learn from all these cases.
Actually, I would like to agree with what Sir said. this is something which is very much disease specific. Like for ANCA, it has a wide berth. There are lots of diseases where ANCA is raised.
Right.
But you have to consider the autoantibody in place. If I am getting a high titer of anti-TPO in an otherwise asymptomatic individual whose thyroid profile is absolutely normal, obviously I will advocate for follow-up, say for a reasonable period of time. There must be a certain degree of caution exercise. If I'm getting islet cell antibodies or the zinc transporter 8 antibodies, which are extremely specific to the endocrine pancreas, then of course follow-up is extremely mandatory in such a case. And our platforms, especially the current ECL platforms, they utilize a very low level of serum. So even that is very important. The bridging ELISA, that also utilizes a very low volume of serum. When you're talking about children and adolescents, they are going to come every 3 months. These are some of the practical issues also which are at hand. So if the lab is going to cater to a certain subset of population, those technologies must be in place for the lab. Then only it is easier for us to advocate serial follow-ups. So that again is, ma'am, something which should be disease specific. And we should take the call accordingly.
There's a
Right.
genetic component here. As you know, autoimmunity has a genetic predisposition. So if you have a sibling who is already diabetic and the other sibling is presenting with you positive antibodies, but he doesn't have diabetes at that point of time. So if you already have a sibling who has diabetes, then you should be careful. You know it's coming. So.
Clinical history is very important, actually.
And in fact, genetic susceptibility testing is pretty much advocated for these disorders, like the autoimmune thyroiditis, like the juvenile diabetes, and they do correlate very well with biochemical tests. There have been actual publications to that effect. So like what Sir said, it is always we have to approach it in a synergistic fashion. It just cannot be a single one test, one time point.
Right.
May I add something, ma'am? Yeah, as Dr. Sarkar mentioned, this is the most important question of this panel discussion. Whether we should treat the antibody or the patient. The answer is simple. We do not treat antibody, we treat the patient, we treat the disease actually. If the disease is present, we are going to treat. I'll give one example, but there are some borderline cases. I'll give one example. Say one patient patient came to us, I'm a rheumatologist, so one patient came to with generalized pain or polyarthralgia. There is no clinical sign of synovitis, no joint swelling, no joint effusion, nothing. Say the patient came with high titer of say 200 of anti-CCP. So what are we going to do? Are we going to treat the patient with methotrexate, steroids, or NSAID or something like that? These are borderline cases because there is no frank synovitis. So we look for any subclinical synovitis here. We use high resolution ultrasound of the joints to see whether there is any subclinical synovitis. If there is subclinical synovitis, that means it's only a matter of time when the patient will develop overt disease. So if we find subclinical synovitis, we will treat. If we do not find, we won't treat. So that means if there is underlying disease process going on or not, that we have to confirm after getting the positive antibody. Thank you.
Right. So what we always know that, and what we understand is very important, that we need to have a proper coordination, clinicians speaking to the laboratory consultants, understanding the disease process, moving ahead and working in a coordinated manner, so that actually what you told right now, the ultimate we are going to treat the patient. That is what we all aim for. So I would like to ask Dr. Saikia, we have got a plethora of tests. As I told initially, last 2 days we had been hearing and listening to all those. So how do you proceed towards the judicious use of the autoantibody testing? Though we have discussed, but I felt this is pretty much relevant when we are having the eminent clinicians with us.
Okay. So judicious use, it's actually true for all the laboratory tests that you do. But with regards to ANA, I'd say that ANA is one of the most over-ordered tests, and the positive predictive value of the ANA is not very high. So it should be the clinician's instinct as well as laboratory person that you do ANA only when you actually suspect autoimmunity, and you have to be careful. You just don't order an ANA blindly. So, rest judicious use, I think we have already discussed how to go about the whole thing. Yes.
Okay.
The
Please,
same
Patru.
holds true for ANCA testing also, because the consensus, they stressed on gating strategy. Gating strategy, only the patient if presented with RPGN, only having some pulmonary and renal symptoms, multiple lung nodules, and there is list of things, then only you can go for ANCA testing. There, so before it was like, irrespective of this specific list, they order for ANCA testing. Now it has been changed. in
True,
the
that
recent
is what. The
consensus.
clinical correlation is very important actually for anything we do. Okay, we have discussed a lot of other things now. Let me go to Shangumitra to understand what are the relevant hematological tests, which are the routinely used ones, but which helps in diagnosing or which aids in towards how to move about this particular disease. It might complement, it will supplement regarding.
There are not many specific tests, but routinely CBC we get in a lab for all types of diseases, even autoimmune diseases. And normocytic normochromic anemia is what we see. That indicates the chronicity of the disease. One thing I want to tell you, ESR, though it is a very non-specific test, but